Thank you. Thank you for that very kind introduction. Thank you. So my talk is going to be very different from the last couple of presentations we've had. So I'm going to give you the broad context of cancer, and I'm going to place this in the context of clinical challenges, both for healthcare and the opportunities that you have in your career to make a mark using some of the work that you've heard and some of the work that you're doing now. So where does your work fit in to the broader space of cancer and healthcare in cancer? So I'm going to talk a little bit about cancer itself, what cancer is, what the biology of cancer is. I'm going to introduce you to cancer treatment and the principles of management of cancer treatment, talk a little bit about the burden of cancer in India, and then what your challenges are and what your opportunities are in machine learning. So for those of you who come from a biology background, you know that a cell is a work of art, okay? So there are cells everywhere in our body, each of them performing a unique function. And to be a cell is to be a tightly regulated organism. So you know when you're going to be born, so when you're going to split off, you know when you're going to mature, you know when you're going to divide, and you know when you're going to die. I mean, I don't mean cells are sentient. What I mean is that this is all tightly programmed and tightly regulated. However, it is possible for a cell to change, and we'll go through the process of change in a little while, and to become uncontrolled. So instead of growing, maturing, and dying, as cells should do, cells can then escape from these regulatory mechanisms and become uncontrolled in their growth. They can then, all cells sit on a membrane, so they can then invade that membrane and they can spread. Okay, so they transform from being normal, tightly regulated functionaries to being little aliens. Okay, not little aliens, terrible aliens. And we've known that cancer exists for a very long time. It's there in Egyptian papyrus, and Hippocrates, I think, described the difference between a benign, which means an innocent or a non-cancerous entity, to a malignant or a cancerous growth. So cancers arise from normal tissue, and any normal tissue, normal body, can become cancerous. So a cell from any part of the body can change from this tightly regulated unit to being an uncontrollable, pluripotent thing. The majority of these tumors arise from what we call epithelial tissue, which is epithelial tissue is a way to describe the lining of the body. So the lining of the tummy, the lining of the gut, the lining of the uterus, the lining of the lung. These are all, so lining tissues are called epithelial tissues, and the majority of cancers arise from epithelial tissues. The majority of tumors, and a tumor just means a growth, but the difference between a benign tumor and a cancerous tumor is that in the end, a benign tumor has to stay where it starts, okay? So you can have a breast lump, but that breast lump will stay in the breast. It doesn't go anywhere else. It basically stays in the breast and it cannot invade, okay? So a critical part of being called a cancer is that you have to demonstrate that that bunch of cells that has grown has gone through its boundary and has escaped, okay? That invasion has to be present on a slide for a pathologist to be called, for the pathologist to call it as cancer. If it isn't that, then it's a benign tumor. And the majority of cancers will be either squamous cell cancers, so skin, mouth, oral cavity, the cervix. These are all squamous cell cancers. So squam is a way of describing a particular type of cell that looks like a flat pavement type cell, or it's an adenocarcinoma, which means it arises from glands. I'm not going to do any more histology, by the way, don't worry about it. The alternative is that you can get cancers that arise from tissues that become connective tissues. So these are sarcomas, the blood cancers, the neuroectodermal tumors. These are much rarer than the epithelial cancers, but they're treated quite differently, which is why you have to start with this distinction. Now, for a cell, which is an extremely tightly controlled unit, to become a cancer takes time, okay? People ask me all the time, how long have I had this cancer? That is an unanswerable question. You can model it, and that's possible. For that individual, it is impossible to answer that question. The key thing that you need to remember is by the time you see it on CT scan, so for a CT scan to call something as abnormal, it needs to be 1 centimeter. You get away with 8 millimeter. But that 8 millimeter is very old, okay? Because a cell is microscopic, and for a cell to become a cluster of cells, to become an uncontrolled growth to the point where you can see 1 centimeter, it's been around for some time, okay? Now, I need you to remember this, because remember, the way we're detecting cancer at the moment is based on an entity that is already 1 centimeter in size, okay? So it's already grown to a point where you can see it through imaging. I think the future of cancer is going to be about us being able to see cancer much earlier than that. So for this process to happen, you need 5 or 10 critical things to change. And a mutation, for those of you who know biology, it's a change of a protein product. It's a DNA sequence which is, DNA. So you have CTAG, CTAG, and then something changes in that, and the protein product that comes from that sequence is a non-functioning protein product in some way, shape, or form, or it's an aberrant protein product. So you need 5 to 10 critical things to happen in a cell for that cell to become a cancer. And these mutations can happen either in the germline, so you've inherited it from your parents, or it can happen so you have acquired it over a lifetime. Now, it's perfectly possible to not have a family history. Family histories are very odd things, by the way. People don't tell you the truth half the time. But even if your parents didn't have cancer or your immediate family didn't have cancer, it is still possible for you to have inherited something from the germline, which means in germline basically inherited stuff. Because just because you have a germline mutation doesn't mean you manifest it. Okay, so it's perfectly possible because of a lifestyle issue that you've inherited a high-risk susceptibility gene, but it's not there in your family line because for some reason they didn't manifest it. Because penetrance is not absolute in the sense that you can inherit a cancer-causing gene. Penetrance is the manifestation of it, but penetrance is never 100%. So it's perfectly possible for you to carry a gene and pass it on without actually knowing it. But most commonly, cancer occurs because of changes that are in somatic cells. That is, these are cells that are not inherited cells. These are cells that you have basically produced in your own lifetime. And through the way we live our lives or the way things have happened. And besides, the other thing I really want to start by is getting one of my hobby horses. Please don't do this. Cancer is karma. Cancer is destiny. Something bad happened. I did something bad in my, this is all victim shaming. Actually, it's not helpful. It's terribly unhelpful. These things, road traffic accidents happen. Cancer happens. Okay, so why do you get these mutations? You need genes that normally control growth, that pass on signals, that cells die, and this, a cancer cell does not die. It prevents itself from dying. And it basically, there are a number of genes, and I'll come to a beautiful picture in a minute. These are the things that have to change. Now, anyone's interested in this is the Hallmarks of Cancer paper. There are 3 of these papers over time. And this is the most recent Hallmarks of Cancer paper. And this is a complex picture, but this describes the kinds of changes that need to happen. And you don't need all of the hallmarks all the time, but you need the majority of hallmarks of cancer to be present for a cell to become cancerous. So for example, a cell needs to evade growth suppressors. Eventually a cell will be told, stop growing. So it needs to evade those signals. It needs to avoid being killed by one's own body. It needs to attract blood vessels to it. It needs to promote inflammation that helps it grow. It needs to change the microbiome around it. It needs to be able to eat up the membrane and go through the membrane. It needs to avoid senescence. Senescence is aging. Basically, we all age. cancer cells don't age, actually. They avoid senescence. They're incredibly clever, difficult things because cancers almost jump one step ahead of how hard you're jumping. And I've certainly seen it in patients where, you run and the cancer is running faster than you. They resist cell death. So these are the sorts of changes that need to happen. And this is quite a useful paper to read if you want to read the whole, if you want to see cancer as a whole, then this is quite a useful integrated mechanism to understand why this happens. So how do mutations arise? We know that cells divide and these are tightly regulated, but essentially it's a set of codes that needs to be replicated. And in that replication, you get errors. And eventually, if enough errors accumulate, you end up with a cell that's free of its control mechanisms. And this is a direct byproduct of aging. And this is a reason why in the UK, you have a 1 in 3 lifetime risk of cancer. So essentially, across your street, 1 in 3 people over their lifetime will develop cancer. And that's because of a population that is aging. One of the reasons why India's cancer burden is so low at the moment is because it's a relatively younger population. So there's more time to get communicable diseases. There's more time to have road traffic accidents. But eventually this is shifting, and this will shift as a society matures and a society ages. You will have the risk of having more cancer merely by the fact that your copying errors have changed and have increased over time. One's exposure to different agents like carcinogens, for instance, increases. And carcinogens include tobacco products, the human papillomavirus, that is high-risk human papillomavirus is the cause of cervix cancer. Obesity, which is not so much a factor in India yet, but certainly a factor elsewhere. You have UV light and sun rays causing melanoma. We've got smokeless tobacco, and we heard about that for oral cancer. So there are a number of these different pollutants that exist, and these are all carcinogens because they all cause the cells to change and reduce the ability of an individual cell to obey the regulatory mechanisms that surround the cell. Okay, and this is again a really important slide. Okay. In the ideal world, and there are some cancers that follow these rules, colorectal being one of them, cancer is a progressive multi-step disorder. How quick that progression is very cancer dependent, and not all cancers follow this very beautiful paradigm. But in the best case scenarios, this is what it looks like, which is that you have normal cells, okay? They have mutations, they become early, adenomas are still benign. So you have a small lump there, okay? That's the basement membrane, you can see that's intact. So it's an early proliferative growth. So there's still a growth that you can see, there's still a change, but you're not going to die of it. It's absolutely fine. That changes over time to a late adenoma. So this is bigger, it's sitting on the basement membrane, and KRAS is mutated over this. And so things are changing. The adhesion factors are changing, the signaling factors are changing, the growth factors are changing. Then eventually the policeman of the genome, the P53 is lost. And then this then becomes a carcinoma. You start getting angiogenesis at this point because the cancer cannot grow without getting new blood vessels to form and to grow towards it. And if you have this sequence, there are a number of different implications for this sequence. And the most important implication for a medic is that potentially if you can pick this up across here at an early adenoma stage or a late adenoma stage, then there's things you can do. So for colorectal, for instance, this is the reason why you have the FIT program, which is a sort of modern manifestation of the occult hemoglobin. So if you I don't know if you guys remember this, but we used to screen for blood in the stool. Now you can do more complex tests, but fundamentally these things beyond a certain point in time, they bleed into the bowel. And you can pick up the hemoglobin. If you pick people up at this point, you can just remove the polyp and see what it's looking like and stop this progression to cancer. Okay. So as I said, in the ideal world, this is you know this for a cancer, and these are cancers that are perfect to set up screening programs for. So cervix is a great example of a cancer where you know the pathogen, you know that cancer is caused by human papillomavirus infection, and to have cervix cancer or to go for cervical cancer tests does not mean people have had a particularly interesting life. It just is one of those things. HPV is incredibly ubiquitous. So it's, again, I'm not a great fan of stereotyping people. So to get HPV infection, there is then a lag period of 10 to 15 years before they develop cervical cancer. So there's a huge opportunity then to be able for us to vaccinate our youngsters, our young girls and boys for HPV vaccination, and then to prevent cervix cancer over time. Okay, breast is a great example, although breast, there's different things around breast in terms of not all, and breast, prostate, colorectal, cervix, these are all great examples of slow growing cancers that have a very clear phase. So in summary, cancer can originate in any tissue. Cancer is a genetic disease, and it's driven by mutations in genes controlling vital cellular processes. And it's a progressive disorder. So you start from a tightly controlled cell, you acquire things over time, and this then becomes cancer. Okay. So where do you guys fit into this? I'm going to give you the crash course on cancer treatment. Okay. It's actually not that difficult. So to figure out what you want to do for any solid cancer, I'm not talking about the blood cancers, they're a whole different entity. For any solid cancer, okay, there's just three things you need to know. Where is this cancer from? Okay, what is the tissue of origin? Has it spread? Has it not spread? And how aggressive is this? Now, these actually, medicine, we haven't changed now for about 60, 70 years, okay? So this is pretty, we try and overcomplicate this, but fundamentally, this is how it works. So if somebody says they've got cancer, three questions. Where's this cancer? Has it spread? How aggressive is it? That's it, okay? And all treatment, everything in the world stems on this. Now, the reason why you need to know the tissue of origin is because treatments depend upon the tissue of origin. In order to know the tissue of origin and to make a diagnosis of cancer, you need one test, and that is a biopsy. It's not possible to say somebody has cancer or not cancer definitively without getting some form of tissue to look at under the microscope, okay? Whether it's tissues or cells, that is the gold standard of diagnosis of cancer. Now, this sounds very easy, but you have to realize then that obviously you may end up having multiple biopsies before you find this tissue of origin. And I'm going to come back to this point a bit later. You need some form of imaging to see whether the cancer has spread or not, okay? And that's how you figure out whether the cancer is still in the tissue of origin, whether it's spread to the neighboring tissues or whether it's gone elsewhere. And you need some way to assess whether this person is fit, whether they can cope with treatment or they can't cope with treatment, okay? So three characteristics for cancer, three sets of tests for the person with the cancer, and three treatments. That's it, really. You have surgery and radiotherapy, which are the curing treatments for the majority of solid cancers, okay? Then you have chemotherapy, which is phenomenally useful, but chemotherapy is fundamentally designed for cancer that has spread, or it reduces the chance of the, or for us to, so basically chemotherapy is for systemic disease. So it's when a cancer has spread outside its tissue of origin, or cancer cells have spread, that's what chemotherapy can kill. All of these treatments have side effects. There's no cancer treatment unless it's very, very early stage that does not have side effects of treatment. Okay, so that's the trade-off. Okay, so you have some form of cancer. You have to decide the trade-off. How much are you willing to pay for what morbidity you're willing to undergo? And that's the bottom line in cancer treatment. The more aggressive we are with our treatment, the more side effects you have with treatment. And the whole rationale here for cancer is how can we tailor it such that we give enough treatment, because all of these are poisonous treatments. Radiotherapy, you're X-raying, you're basically shooting, Star Wars, you're zapping the patient. Chemotherapy, you're poisoning the patient. Surgery, which obviously is the best thing, you operate and you remove things, but obviously people have morbidity from that. Okay, so then you end up with three outcomes. You can either, unfortunately, die of the cancer, you can be cured of the cancer, or you live with cancer. Okay, right now, the majority of cancer that we haven't really increased cure rates. What we have done is increase the proportion of people living with cancer. So these are people who have, they have cancer, they're treated. Over time, the cancer might return, they're treated again, and then they might be treated again. And the big advance in cancer that we've had actually is in shifting the proportion of people who would have progressed to death into the living with cancer group, okay? But obviously, there's a cost to be paid for this, which is that you have more lines of treatment. So you treated in 2018, then you're treated again in 2020, then you're treated again in 2023, and then you're treated again in whatever, and then the side effects of treatment mount. And the priorities of cancer treatment, as I've explained, are to treat the cancer adequately, to reduce the side effects of treatment, and to monitor the patient so you can pick up recurrence early. So all of this is background, okay? And stick with me because, where you come into all of this is coming in a little while. So basically, it's just three things, okay? Over and over again, it's just the same three things that you just have to get in your head, and you can reduce the complexity of all of cancer to these things, these three things, these three rules over and over again. Why does this matter to you? Which is kind of where I'm going with this. So we have this is yesterday's data, and this is Globocan, the World Health Organization estimate. So today, India's incidence is 1.3 million, but it's actually quite a low. It's a relatively low estimate actually, and it may be that we've underestimated it. That's one possibility. The other reason is because our burden of communicable disease is still high. And maybe that's the reason. You have a proportion of people who will die without a diagnosis, and maybe that's not factored in. We also have a younger population, and that's probably another reason why we haven't got as high an incidence of cancer as one could expect from our population load. So, however, if you look at, this is Indian data again, if you look at the proportion of people who will die of cancer, you can see, so this is data from breast cancer, prostate. So the blue bars represent incidence, that is the number of new cancers in a year. And the red bars represent those who die of the cancer. It's obviously not the same individuals, okay? You don't, very few people will be diagnosed and die in the same year. So there's a different group of people, but it's still a representative group of people. So you can see in the majority of cancers, the red bars and the blue bars are not that far apart, okay? So the majority of people who will be diagnosed with cancer will also die of the cancer, okay? So it's a life-limiting, it's an extremely life-limiting illness to have. So the burden of cancer for these individuals is actually remarkably high. It's also, and this is relevant for you guys who are still early on in your career, this is going to increase. And this is 2023 to 2035. So in the next 10 years, this will increase by about 42%. And that's, as I've already given you the caveat for the incidence. So if anything, over time, we're going to shift from more and more communicable diseases, the more we have sanitary conditions improve. If our road traffic conditions improve, the more we are able to rescue and salvage childhood illnesses, we will also, over time, get older as a society, and our cancer burden will increase, okay? The most common cancers now are changing. It used to be when I was a medical student that cervix cancer was the most common cancer in women. It's actually not anymore. And that's a surrogate for prosperity. Breast cancer is the most common cancer in women now. And that basically, it represents a population that's urbanized, that is getting wealthier, and that is changing in terms of socioeconomic status. So the most common cancers are breast, oral cancer, cervix cancer, gastric, and lung. Of these, we've got at least 3 cancers that have really good preventative measures. Breast, where you have got a good screening program that could work. Oral cancer, which has a pre-malignant entity, which you can at least downstage for, and cervix, which is eminently preventable. Okay, I'd like you to bear that in mind, please. So, this is a really busy slide, but essentially it says what I've just said, which is that the types of cancers are changing over time, and this reflects a society that is changing. So what are the implications of cancer for that individual? It's obviously a cancer that's a disease that's associated with a lot of suffering. Yeah, cancer is not just an MI is a nice way to die. Okay, myocardial infarction, unfortunately, people aren't dying of heart attacks anymore because we treat them with aspirin and statin and clopidogrel. It's a real pain because actually, if you wanted to die, a sudden death is, good going myocardial infarction, nice way to die. It doesn't work like that for cancer. You end up with symptoms, that progress. These symptoms are uncomfortable. There's pain. There is a loss of function. It needs active management to try and make the symptoms more bearable. Okay, so it's not a pleasant way to die. There's loss of life for the patient. There's loss of income for the individual. There's an impact on the family. There are the side effects of treatment for people who undergo treatment successfully. There's impacts on the carers, particularly because these are still relatively in India, not very elderly people. There's still cervix cancer, you're talking about 40, 50-year-old women. And there's an impact on economic productivity. So there's significant impacts. So now, all of this was background. For the next half an hour, I'd like to talk about what you guys are going to do with your lives, okay? So we have this cancer paradigm now, which is not personalized in any way, actually. Our personalization is at absolute infancy. However much you hear about personalization, right now in clinical practice, we're at our infancy. There might be a few cancer centers in the United States where they have a lot of money, where they're doing personalization, but the vast majority of us who treat cancer, and I work in a very highly performing center, we're treating people in numbers, okay? So 100 patients with stage 1 uterine cancer, we treat in this way, okay? So remember I told you stage, grade, and tissue of origin? These were concepts that we have had for 60 years, okay? And that's how we're still treating people. So we've moved from, email addresses came in my lifetime, okay? We now have technology that allows me to see on my phone and it opens my phone. And yet the way I treat patients hasn't changed fundamentally in the broadest concept of it. It hasn't changed at all. So this is the deal. This is the deal that we're treating people on the balance of probability of 100 people with this stage, this grade, this tissue type. 80% of them will respond to X. This is not personalized. This is a numbers game. So I give you the normal standard paradigm of cancer in any part of the world. You have symptoms. Over time, you think, man, this headache's not going away. This abdominal pain is not going away. My stomach is still hurting. Let me go to the doctor. So you go to the doctor. Who knows which doctor you've gone to, okay? So in the UK, you go to the family physician. They take a history, maybe it's 7 minutes, okay? That's the average time a doctor spends with a patient. So in 7 minutes, this person or this man or woman has listened to you and they go, okay, let's investigate you for this. And they send you a list of investigations. Now, this is a highly subjective interaction because it depends upon how you've said these things and depends upon how they've heard these things, okay? So for an abdominal cancer, it's very hard to distinguish between a stomach cancer, a bowel cancer, and an ovarian cancer, actually, because they all are abdominal, okay? They all have similar symptoms. So you go to a gynecologist, they'll get you a gynae set of investigations. You go to a colorectal person, they'll give you a colorectal set of investigations. And normally the way it works, in whichever health system you go to, is you go to one doctor, you get a set of tests, they say, oh, it's all fine, but let me check you out, I'll send you to this other person. Then you go to the other person, then you go to the other person, then you eventually, okay, one biopsy is positive, okay? So this is, I'm not making this up, this is real, okay? This happens in India, it happens in the US, it happens in the UK, this is real. Then you have a biopsy, okay? This biopsy is usually painful, it's invasive, it's a piece of tissue that's taken from you, okay? That is usually through some form of invasive investigation. Then this biopsy has to be reported, and we use reporting mechanisms that were present in the textbooks when I was a medical student, probably when my father was a medical student. You know, he's not a doctor. What I'm saying is, you know, that hasn't changed. Then you do staging investigations because you have to find out whether this cancer has spread or not. So then you go for CT, MRI, PET CT, whatever. So then you come and then you determine your 3 things: your tissue of origin, your stage of cancer, your aggressiveness of cancer. Then you have a treatment plan of the surgery, chemotherapy, radiotherapy. Then I've told you the rest. So this is where we are, and this is a fundamental paradigm. This paradigm is a lousy paradigm, okay? The majority of research that we do in this happens in high-income countries, and the majority of research is done in people of Caucasian ethnicity. And the majority of research in cancer actually happens in drug discovery. And I've got nothing against my colleagues in pharmaceuticals, I'm just saying. So there's no major incentive to change this paradigm. So this is a copy-paste from a journal article, the Journal of Clinical Oncology, which is highly regarded, 2022, so last year. And this is an analysis of benefit of all FDA-approved new cancer drugs, okay? So novel cancer drugs increased patient survival by a median. I'm not talking about, so this is a median of 2.8 months, okay? With an interquartile range of 1.97. So that's 2 months to 5 months for overall survival, i.e. you've spent 100,000 pounds, your relative has survived 5 additional months as a result, at the best case scenario, okay? And 3 months for progression-free survival, which is, you know, progression-free. So overall survival is the date of diagnosis, date of death, which is probably the only statistic that really matters. But we can game the system. We can say how well did this drug impact the next cancer recurrence. In the meantime, you have mortgaged your home, you've sold your land, you've sold your jewelry. This is the price, okay? And this is the majority, this is the median of FDA-approved new cancer drugs over the last 20 years. If you look at more personalized drugs, it's a little bit better. But you have some amazing drugs for melanoma, for breast. You have these standout examples like Gleevec, and these are fantastic because they've transformed care. But those are few and far between. And you have some immunotherapy drugs, which again will transform care. But again, these are few and far between. And I need to emphasize this. These will all buy time. They will not transform care to normal lifespan. They will, we haven't shifted it from cure. We have shifted it from death to living with cancer. Okay. So this is something that you really need to take home. So where do you guys come in? So where we are, I think, for the next 10 years, next 15 years, no system in the world can afford what we're doing now. And I haven't put up the cost slides, but it's fundamentally unaffordable. The way it works with cancer drugs is you have a new drug, you have a positive trial. You don't need much for a positive trial, right? You need 2 months for a positive trial, 3 months for a positive trial, because these trials are done in advanced or metastatic cancer. So three months is it usually will be heralded as a wonderfully positive drug. You probably, so that then comes into domain. It's spread amongst the public, it's spread amongst medics. There's usually patient lobbies that lobby for this to be approved in public health sector systems like mine, and it gets prescribed. But we cannot afford this. No one can afford this. The US can't afford it. The UK can't afford it. India certainly can't afford it. So where do we need to be? We need to be much more upfront than this. So can we prevent cancer? So we heard yesterday about, we heard day before yesterday about Professor Gill's talk about oral cancer. Are there ways in which we can collect data from wearables, from public health records, from exposures, multimodal data to identify people who are high risk, people who can then be used to screen in a different way? Can we diagnose cancer early? And I'll show you some work that we've done using supermarket loyalty card data. And when I say diagnosing cancer early, remember I said to you, for something to be seen on an image, it needs to be 1 centimeter, okay, or 8 millimeter, for it to be seen on an image and considered abnormal. But by then, that cancer is at least months old, if not years old, okay? So, and I've told you, I've shown you all the changes that are happening. If you look at the equivalent to pregnancy, you don't need to miss a period to be positive for your pregnancy test, okay? You urinate on a stick, it's positive. Meanwhile, you can't see a fetus on an ultrasound, okay? And that's because we know that pregnancies produce a lot of human chorionic gonadotrophin, and then you can have a very sensitive urine biomarker for HCG. And we've known that for hundreds of years. But it's the same process. You have a baby has processes that are not dissimilar to cancer. This is an alien product. It's an alien product that's growing in the uterus. It's releasing things into the mom's system. Okay, so we have cancer products that are being shed into the system, and we've known this for a long time. So we can diagnose cancer earlier, and we just need to figure out ways in which we can do this. Can we do this without invasive tests? I've told you about the ways in which people go from one specialist to another specialist, enduring one set of tests to another set of tests. Are we able to do circulating tumor DNA and look to see whether this person has cancer and where this cancer comes from? And again, this is work that we're doing. I've got a couple of slides on this. Can we speed up testing? So the major pinch point in cancer, apart from the fact that we have few surgeons, few oncologists, is actually that we don't have any pathologists at all. I mean, if you look at African countries, they barely have any pathologists. So this is a major crunch point. Pathology is a total crunch point. Radiology is a total crunch point. So are we able to do novel imaging? And you heard a little bit about that. Can we treat cleverly? We currently operate. I operate in the same way that I was taught to operate as a medical student, okay? I've learned from my mistakes. I've learned from my seniors' mistakes. And God willing, my juniors will learn from my mistakes. That's an insane way to learn to operate, okay? So I'm learning robotics now. I'm quite a late entrant to the game. And actually, I can easily see how in 10 years' time, right now, robotic surgery does not have sensors, so there's no haptic feedback. But if you look at the airline industry, they're not reliant on one airline pilot making mistakes and learning. They're reliant on a whole computer system that supports the pilot to learn. So I genuinely believe, and my surgical colleagues will probably kill me for this, that we will move to an environment where at least the standard operating will be transformed by the robots that we're using saying to us, are you sure you want to do this? Why not? Why should everybody have to learn from somebody else's mistakes? This is crazy. This is kind of insanity. Planning radiotherapy, we heard about contouring. We had a beautiful talk from Hannah Thomas on how we can plan radiotherapy better. And again, radiotherapy time is expensive time. So if you're able to contour using machine learning, then that would be wonderful. Can we use omics to stratify cancers into those that will have poor outcomes versus those that don't? So are we able to use all of this multimodal data, this clinical information, the information from the tumor, the information from the imaging to predict those that will, can we build prognostic models that will say these patients need more treatment, these patients need less treatment? And can we minimize side effects by understanding what the individual genetics is for people who respond to radiotherapy? These are your questions. These are not going to be, well, these are my questions too, but in a sense, this is what is going to be the questions that will matter to you going forward in your careers. So I'll give you two examples of what we have done ourselves. So some time ago, a couple of years ago, we got together with the folks in Imperial. So this is a collaboration between Imperial and Birmingham. And we said, you know, these patients, before they go to the doctor, most of us, we self-medicate, right? I've got tummy pain. I'll have some paracetamol. I'll have some Gaviscon. I will eat jeera water. That's my mother's solution for everything, have jeera water. So the point is we're doing things before we go to see the doctor. So what we then said was, if there was a way in which we could use supermarket loyalty cards. So, you know, when you go to, I don't know, Fab India or one of the shops, they say, what is your mobile phone, sir? And then they send you emails and then they send you texts. But they have your purchasing data, okay? And so in the UK, we only have 4 or 5 supermarket chains. So most people shop in those supermarket chains, and everybody, including me, we have a loyalty card. So you every time you purchase, you zap your loyalty card, and it collects your information, and it gives you a few points that you can redeem for something like, you know, free ice cream 6 months online. So technically, you should be able to collect this data and see whether people are purchasing differently if they've got cancer or not. So that's the study we ran, where we pulled supermarket loyalty card data, and we compared it between people with cancer, 185 people with cancer, a similar cohort of people without cancer, and looked at their purchasing patterns. Now, this is big data. I mean, not this particular one because we have relatively less numbers, but still we're looking at purchases on a weekly basis for a year, 18 months, 2 years before a diagnosis of cancer. And then we were able to show that there's a difference in purchases of pain and indigestion medicine amongst women with and without ovarian cancer about 8 months before the diagnosis. Now, remember, diagnosis, I've already told you, it takes time to get a diagnosis. So from seeking help, seeking help from a medic to, so there's probably a 5-month interval where potentially, sorry.
So you're talking about the loyalty cards. So maybe one can use their card to purchase drugs for other person in the family.
Right. So this is a very good, so thank you for that. That's very helpful. So this was a complex project to run. And so we had a number of issues to address. Usually the woman is the woman who's buying for the family, okay? What we, in most societies, it's still, unfortunately, the women who do the shopping. So you have to subtract that data. You have to subtract the possibility. And it's even now it's possible that actually this is not a truth because this is a feasibility study. We're wanting to replicate this in a larger, we've just applied for funding for that, to look to see whether it's real or not. But our feasibility study was to find out whether we can do this work. Because remember, there's lots of data privacy issues. I don't know just about your pain and indigestion medicine. I know if you're buying alcohol. I know if you're buying condoms. I know who you are based on your purchasing patterns. Okay. So how do we, so we had to do lots of work around, is it acceptable for us to get purchasing patterns? Is it acceptable for us to ask cancer patients to release their purchasing patterns over 2 years? How do patients feel about, and this is data that was given to the supermarkets. Okay, so that they're here, we're now, these were not health people. These are people who you are having transactions for in a commercial space. Okay, and we're wanting to link that data and look at that data in a completely different context. So actually, we had two huge big supermarket chains that were happy to play ball, which is quite amazing. And you could, you can see what their commercial concerns would be. So we had to do lots of work around data privacy, and then we got our controls and age-matched controls from the community. Okay, and that then brings us back to bias, which is the people who are willing to share this data with you may or may not be representative of the people in aggregate. So yes, with all of these caveats that people are buying it for somebody else, that there is a possibility that actually it's a completely unreal signal, that this is not true at all, that if you translate this into a larger study, a properly adequately powered study, because this is a feasibility. This was a study to say, will people consent? Can we overcome data privacy issues? Will people share data? Can we analyze data? So that's what the study was about. But you can imagine that this is the sort of space where machine learning would work very well, because you're looking at lots and lots of variables, lots and lots of patterns, and lots of heterogeneous data over time to release this. Okay, so but I am quite excited about it because we have multiple interactions in life before we see medics. I don't know what the equivalent in the Indian setup would be, but we are always interacting with some form. I mean, we wear wearables, we have ration cards, we have so many different interactions that it's possible to identify, and other people do it all the time. So if you're just emailing or tweet, searching for something on Google, an ad pops up. Okay, so and there's work around things like, and I certainly have done myself, on forum searches. If you can mine online forum searches, then you can figure out what people are having. But that I'm really uncomfortable about the privacy issue, because if the search patterns for pregnancy are more, can actually accurately predict whether somebody is actually pregnant or not. But then we're really skirting. There's lots of issues and ethical conversations we need to have about, is this appropriate? Is this, where do we stand on data privacy for these things? But, this is potentially quite exciting. We've published, this is Cancer Research UK funded. We've applied for a larger study. Hopefully, if we get this, and if that result is positive, then we're in a slightly different space, because we can use this model for other models. And we are exploring machine learning now for the data that we have, because it's multimodal, it's heterogeneous, it's complex, it's big data. So these are the things that we're doing. Shall I take more questions at the end? Is that okay? So the other things that we are doing. So I told you, why can't we look at a blood sample to pick up cancer? So this is something that we're doing with Cambridge. The analysis is ongoing at the moment. We look at circulating tumor DNA, we're looking at methylation assays, whole genome sequencing, copy number variability, and again, different assays. And we're going to combine them into a model, hopefully, God willing, to look at whether blood tests can diagnose ovarian cancer earlier, or tests can diagnose circulating tumor DNA in some form or the other, can be combined with clinical information and protein information, biomarker information, to diagnose ovarian cancer. And this is a collaboration between Cambridge, us, and UCL. We've got another grant for looking at urine metabolomics. So before steroids are produced, obviously there's lots of immature steroid metabolites. And we have data. We had a previous PhD student who demonstrated that it was possible to look at urine immature steroid profiles to flag up a rare kind of cancer called mucinous ovarian cancer. And, we've now funded for a national and international study. So these are some of the things we're doing in the diagnostic space. And tomorrow I'll talk to you about what a test needs to satisfy, what a machine learning model, which I'm going to call a test, needs to satisfy to be of any use in the clinical space. So these are the sorts of things that it's possible to do. And these are the things that we are doing. So we're funded, we've got these studies going. We haven't started machine learning yet. We are going to be doing machine learning. But the point is that for you guys in your careers, we need to have transformative cancer research, because really no one can afford the kind of cancer costs that we are running into. And in some ways, if you're going to give people expensive drugs that are going to give lots of side effects that don't restore life, then as a society, as a world, we need to be asking ourselves, hang on, we need to be moving in slightly different directions. And my personal bugbear is that we need more cancer research in diagnosis and prevention. We need more research that is country specific, country relevant. And we need research across different ethnicities. And I've got lots of work in this space if you want to come and have a chat later on. So with that, I will stop. And I tried to do this graphically, but it didn't work. But anyway, so happy to take questions.